Good afternoon. This is Dr. John Bennett, broadcasting for MedGadget.com. Today we have the pleasure of having Rosemary Cunningham of Episurf.com, a medical device and application company based in London, making orthopedic type of devices that are collaborating with Touch Surgery to make an animated. We'll find out more exactly what that collaboration consists of. Let's first introduce Gene Ostrowski, the Med Gadget editor. Hello, Gene.
Hi, I'm Gene. Nice to meet you, everybody, and thank you, Rosemary, for coming.
My pleasure.
And, looking forward to the conversation.
Okay, Rosemary, why don't we just start off and just give a general description about your company and how you got to be where you're at and what you're doing, etc.
Okay, well, it's really a pleasure to be here. We always love talking about the Episurf story. Just so everybody knows that we're actually based in Stockholm, Sweden. So that's where the our home market is and our home office is. But we are a European company right now, so we have a presence in the main European geographies. So what it is that we actually do is we make small personalized implants for early stage cartilage lesions of the femur part of the knee. So obviously that is the end of the thigh bone. So we treat lesions in the condyle end of the femur, or either side of the femur, and then also the trochlea region behind the patella on the femur. These are lesions that really develop in younger patients. They can emanate from traumatic injuries. Say you're playing football and you might have a knock to the knee, or skiing. And we see these lesions really kind of take hold in middle age. And these patients are way too young for the more traditional, larger prosthetic treatment, whether that be a partial or a full knee replacement. So we're filling this, I guess you could say, this treatment gap that exists for the younger to middle-aged patient, to up until they're ready for a full prosthesis. So these are tiny cobalt chromium implants. They're personalized for the actual defect. And the way that we do that is we get the patient's MRI. And then we create a perfectly 3D rendered image of the MRI, where we then mark out with great specificity the actual cartilage lesion, not only on the surface of the cartilage, but also looking at the underlying bone, the underlying quality of the bone. You can imagine if you're trying to fix something into a underlying subchondral bone bed that's bad, you don't want to do that. So what I really think is interesting about Episurf is, yes, we make these small personalized, medical prosthesis, a mini medical, it's a small prosthesis, but it's the way that we do it using this very high-end IT platform to mark out the damage, assess the damage. We send that report then to the surgeon, and we have a conversation with the surgeon about the patient's actual damage in the knee. We suggest an episealer if an episealer is suitable for that type of damage. And if the lesion is not suitable for that type of damage, we also tell the surgeon that, and then the surgeon can consider other clinical treatment options. So it's quite new, that in the sense that it's made for your knee specifically. We've done 137 implants so far, so we're quite young still. We've got good 1 and 2 year clinical outcome data that is building. We are showing statistically significant improvement in all of the KOOS domains, and that would be the knee osteoarthritis outcome score measure that's typical when you're tracking prosthetic implants. And we're also showing great improvement on the visual analog score measure in terms of pain. So we have great stories about people who've been, really out of action, young people, middle-aged people who've been out of action prior to their episealer. They get their episealer put in, and boom, they're back to great health and activity.
Okay, Rosemary, why don't we just go through your website so we can get a good overall picture of what you're doing. I find that sometimes that works pretty well. Can you see it okay?
Absolutely.
Okay, okay. Just tell me where to go, and we'll continue on with explanation of what you're doing.
Well, I think if we maybe talk about, talk about the technology, if we start there.
Okay.
Yeah. So, I mean, we have a great process. It's a really slick process, and it starts with a patient presenting, to the surgeon saying, I'm having this knee pain. What do I do? The surgeon takes a look. They have an MRI. The MRI is sent to us. We then assess the damage. Like I said, we assess the damage on the articulating surface of the femur itself, and then look underneath into the subchondral bone. Based on what we see, we make a recommendation about whether that lesion is suitable for treatment with our technology. This is quite unique because the surgeons come back to us and say, this is something like I've never seen before, because you are now, really giving me clinical guidance that was previously unavailable. In other words, I'm choosing the right patient with the right indication, therefore increasing the likelihood of a really super clinical outcome. So once we get that report back, the surgeon approves the report we send him. We then actually go into final design and production. So it's a precision engineering production process that produces the episealer itself, the implant. And what's important is when the surgeon places the implant and actually does the surgery, the tools used in the procedure as well are also patient specific. So they are manufactured to meet the dimensions of the actual implant itself. So you're getting this really precise, targeted fit, correct fit in the right area where the lesion is. And in terms of just like cost and just-in-time inventory, our customers love it because it's literally an implant in a box. They're getting the episealer, and then 7 tools come in a very discreet, one-time use, offering, and completely disposable. The tools are disposable, and they get it in a just-in-time fashion. So the whole thing from start to finish, from the time we get the MRI until the implant is ready, it's on average, it takes about 4 weeks.
Okay, Rosemary, do you mind if we ask you a few questions right now while we're on the technology?
Please, I've been doing a lot of talking.
Oh, that's okay. Okay, Gene, do you have any questions about the technology of Episurf? Hello, Gene, are you there? Well, I have one, Rosemary. What substance do you use? Do you use actual cartilage, like from cadavers, or 3D printed cartilage, or stem cell cartilage? What do they put in there?
Oh, the implant itself is metal. It's made of cobalt chromium, and
Okay.
it has 2 types of coating on it, and these coatings are applied to encourage a bone fixation. So there's a coating of titanium, and there's a coating of hydroxyapatite that are sprayed onto the actual implant at the stage of final production.
Okay.
And so that allows fixation to occur without the use of cement.
Oh, okay. So no cement is used, just a tight fit.
Correct.
And then eventually the cartilage will grow around it, or
That's absolutely right. We can definitely see from our preclinical work and from our preclinical work in sheep that there is absolutely very good bone fixation. The actual peg of the implant, there's a fixation, we call it osteointegration. Okay. So you can show the bone growth. You can see it actually around the stem of the implant.
Okay. Very good. We have another medical student from Romania that joined us. Francesca, hello.
Hello. I'm sorry I'm late, and thank you so much for letting me be here. It's really interesting, the subject, but I only saw the part about the knee. Is there any technology for spine surgery?
Not yet. That's a great question. I mean, obviously, we're still a young company, and we've been very much focused in the knee area, but we do have ambitions to move into other joints, and we're actively getting requests from other surgeons right now, to apply this patient-specific approach into other joints, specifically the ankle and the hip.
But basically, you'll be dealing with some weight-bearing joints, correct?
Correct. At the moment we are the lower extremities. Yeah, the knee. I mean, the only product we have on the market right now is for focal knee lesions.
Okay, is this technology, well, you haven't done the hip yet. Would that be the next joint to tackle, you think?
It would probably, if you look at the market and you look at where the issues are, related to these types of lesions, it will be more likely the ankle.
Oh, the ankle, okay. Oh, that's
Yeah.
interesting.
Yeah.
That's very interesting. Okay, do you want to continue on with some explanations or other pages or?
Let's talk about the products.
Okay,
Okay.
okay.
So, again, this is all about the patient-specific fit. We know we're all unique individuals, and we're all different sizes and shapes, and of course that absolutely applies to our joints. So I think it's quite interesting when you look at the data, you look at patient satisfaction data related to the outcomes of, say, the larger knee prosthesis. You're always getting about 20 to 25% of patients that are just they're just dissatisfied, and they're dissatisfied because they feel that their full health hasn't been restored. When you replace a joint, you're never going to get back to really full joint normality. But what we do with our technology is, because this is patient specific, for the exact size, not only dimensions of the defect, but the depth of the defect, the clinical results that we're getting and the patients that we've treated have really been really amazing. Patients are getting back to, sporting activity, really active people who were suffering from a lot of pain that was coming from, issues within the subchondral bone. So the patient-specific approach is, there's no doubt that it's really working. Now, what our surgeons love is I guess you could say, the guesswork around placement of the technology is eliminated, because we give them a final design and a pre-surgical planning report, along with the guide. They're like a jig. It's a personalized jig they use within the surgery that allows the exact placement. So there's no guesswork for the surgeons. And what's really interesting, when you look at our clinical data, we don't have any revisions yet. And revisions are, they're fairly typical when you put in a prosthesis. But we haven't had any, and we're fairly convinced that it is down to the patient specific approach of our technology. So the right fit, the right tools. We're using the coatings, the hydroxyapatite and the titanium coating, to encourage the bone fixation. At the beginning of our interview, I talked about the areas of the knee that we treat. So if you want to scroll down maybe a little bit on the...
Okay, let's see, I'll try to. I don't know why I'm not able to scroll here. A technical problem. Well, I guess you'll have to just explain it. I'm sorry about that.
I mean, we have two condyles on either end of the femur, a medial and a lateral condyle, and then behind the actual kneecap, the patella itself, is the trochlea groove. So they are the areas of the knee that we actually treat, and that's where these focal lesions tend to appear. So we cover those areas of the knee at the moment.
Do you deal with Osgood-Schlatter disease? Is that a large, sizable population?
I'm not familiar with that disease.
That's a cartilage defect. I think it may be in the tibia, but it's a cartilage defect in the knee.
Oh, well, no, because we're treating that's a great. Well, that brings up a great point. Because we are treating the femoral side of the knee, a contraindication for use of Episealer is having any kind of defect or lesion, kissing lesion on the tibia.
Okay.
So we need to make sure that the tibia is in pretty good shape and is intact. And the way we do that, of course, is through analyzing the MRIs that come through. And if it looks like the opposing tibial cartilage is not substantial enough to absorb, the weight-bearing impact of an Episealer, that's a contraindication. And we would go back to our surgeon and say, no, this patient is not appropriate for an Episealer.
Oh, okay. What would be the patient demographic? About 20 to 40?
Well, yeah, no, great question. I mean, our average patient right now is 45 years old.
Okay.
So these are patients who, the majority of whom come to us, they have had multiple interventions before they get to Episealer. So they may have had ACI, they may have had microfracture, they may have had debridement of the cartilage, the shaving and the cleanup. So 4, 5, 6 previous procedures. We had a patient visit us in the office just Wednesday this week. He had 9 previous procedures before his Episealer. So these are the patients who have failed these other sort of minimally invasive arthroscopic-based interventions, but they are entirely too young, nor do they have enough advanced disease to be suitable for a larger metal implant. We call this the gap patient, or the treatment gap that falls between where these biologic interventions fail and where the bigger knee prosthesis for the older patient starts. Our market information tells us there's a sizable market out there in terms of these middle-aged people who have these progressive degenerative lesions, and they're not being treated right now. They're being told by their orthopedic surgeons, sorry, nothing I can do for you. Your disease isn't advanced enough. Go home, take some painkillers, and see you in 10 or 15 years.
Right.
And of course, we know with today's middle-aged population, that's simply not an acceptable way to treat progressive degenerative cartilage lesions. Our patients need to work. They want to be active. They're very sporty, etc. So one of the things we have seen, and we've seen this firsthand because we know all of our surgeons and the patients that they treat, we're still relatively small. The impact that Episealer has, not only from a pure clinical outcome, but from a quality of life perspective for these patients it's life-changing.
Mm-hmm. Okay. Could you please tell us about your collaboration with Touch Surgery? How that came about?
Yeah, absolutely. You can imagine, as a medical technology company with surgical devices, we have an obligation to ensure that our surgeons are completely trained up to the highest standard when they use our technology. And we wanted, because we have this very interesting IT approach to the way we develop, our own Episealer. We were looking for a virtual solution that would enable us to train as many surgeons as possible, whenever, wherever. We can't be reliant on having salespeople in the operating theater all the time, at every surgery with our customer base. So we came upon Touch Surgery. I personally had been following them for a while, and I knew Jean. I knew Jean through another young orthopedic surgeon based in London that I had been doing some other work with, and met Jean through this other chap, and I really immediately saw. I loved what they were doing because they were using the latest animation technology from, the film industry, essentially, mm-hmm. and making these very, very sophisticated surgical animation training films. So knowing the need that we had to train our doctors, we started a collaboration with them. It's taken, I guess, about 6 months because it's been a lot of work that's gone into getting our surgical animation for our 3 implants, out there, correct, right steps, et cetera, et cetera. And the other thing, what I loved about Touch Surgery is this enabled us as Episurf to demonstrate our technology to a global platform. We are still a very, very small company, but to be able to expose our procedure on Touch Surgery's global platform was really, really attractive to us. And the other thing we like about it is, there's a whole back-end system. It's not just the surgical animation. They provide us with the metrics of the surgeons who are then viewing our animations and simulations, and then that becomes they become business opportunities for Episurf.
Mm-hmm. I would think that would apply for the whole medical device industry if you can get super good animation. that would help the company explain their product and exactly what it does. Gene, do you have any questions of Rosemary?
What hospitals is this is your technology being used in?
Well, right now, we are in various countries in Europe. We're not in the United States yet, so we have ambitions to enter the U.S. and we've begun a dialogue with the FDA. But right now, the product is being used across Germany, across the U.K., across Scandinavia, so that would be Norway, Denmark, Sweden, and then in the Benelux region, Belgium and the Netherlands. We have a great clinical advisory board of 6 European surgeons as well who are advising us, obviously, about all clinical matters.
This is kind of, go ahead, Gene, go ahead.
FDA approval, because these are patient specific, is there any kind of issues with that being more difficult to pass? And also, what kind of clearance do you need?
Well, we're in a dialogue right now. We are in a dialogue right now with the FDA, and we'll come to the the conclusion on that discussion quite soon. But it is our ambition to make an FDA submission certainly within the next year.
Mm-hmm. Now, this question is kind of out of line of what we were talking about, but do the orthopedic surgeons have to use intraoperative MRI for placements? Or I have a hard time figuring out how they know exactly where to put it.
Well, they know exactly where to put it because we give them the pre-surgical reports, so they understand exactly not only the dimensions of the lesion but the depth of the lesion. We have drilling tools that enable them to get to the exact and correct depth that they actually need to get to within the subchondral bone. So yeah, I mean, and it's interesting because when you look at the post-operative x-rays that are taken, it's almost an exact match, of course, with the design that we do and we provide them in the pre-surgical planning report. So it is an exact placement, and they achieve that through the tools and the adjustment socket on the drilling guide.
For someone like the FDA, I'm sure. Do they want to see studies of how long this has lasted? Does it improve patient outcome, etc.? Do they want those kind of results from you?
Yeah, it's interesting. I mean, time is relative, but what they are primarily interested in is seeing these practical improvements in the KOOS domain. The KOOS domains, things like activities of daily living, pain, sport, quality of life, etc. And the other thing they are interested in seeing is I think future cost avoidance is the way I would describe it. So in other words, if you can put an episealer in, for example, in a 40-year-old, how long will that potentially delay the need for a much bigger prosthetic intervention? So the FDA are thinking along those lines. If there's an avoidance benefit here for having to have another procedure 2 years down the line, 3 years down the line, that's attractive to them. We are coming up to having 4-year data right now. At the end of this year, we'll have a couple patients flip over into the 4-year timeline. So far, so good.
Okay. What's the standard of care now if a patient had a cartilage defect in the knee in the areas you cover? What do surgeons do now, like in the United States? Do they just they put cartilage in there? They put stem cells in there? What do they do now? It
depends. I mean, they do all of the above, and that's very much age dependent.
Okay.
So if you're looking at a patient, like say for example, maybe like a 25-year-old or a 30-year-old footballer or tennis player. The surgeons for patients that age, they're not so keen to put metal in the knee in someone so young. So yes, they would do the ACI treatments at that age. Yeah, or yes, that would be the typical type of repair. But what we do know from the data is whilst those treatments look, they look really attractive, they're minimally invasive, they have very long recovery periods as well. Upwards to a year. You have to be very careful about using your knee in a high impact way. But the data is showing that certainly the ACI method over the course of time really doesn't perform well, particularly as the younger patients age and move into middle age. And then that's when they'll get symptoms again. Then maybe they'll try some microfracturing approach a couple of times. And then ultimately they get to that point where nothing's working, they're in pain, and the actual lesion is progressing in size. What's quite interesting, again, what I love about Episurf is this damage marking, this 3D rendering that we do with the MRI, where you're looking at the lesion, very, very well defined dimension and depth wise, and it's certainly our ambition as a company to build that aspect of our business out as a standalone product where it can be used as sort of a screening, I guess you could say, a screening tool for surgeons. You do a simple MRI, you can then track somebody's cartilage damage and progression over a timeline. And then when the time is appropriate, you make the right clinical intervention.
Now, I know there's two ways to get into the knee: an open way, where they open up the knee, or an arthroscopic way. Is this limited? Do you kind of focus on the arthroscopic treatment of this, or does the knee have to be open?
The knee definitely has to be open. It's a mini knee replacement in a way, a mini metal arthroplasty. These are very small. They start at 12 millimeters. They go up to about 20, a little bit bigger than 20 millimeters. But you do have to open the knee. Okay. The average incision size is somewhere between 9 and 10 centimeters long. You have to be able to move around in the knee. You have to be able to push the patella aside. You have to be able to get the guide in the right place, etc. So, okay. Yeah, it is an open procedure. Yeah.
Okay, very good. Gene, do you have questions for Rosemary?
I'm good, thank you.
You're good? Okay. Francesca?
Yes, I have a question. So if we are talking about younger patients, like someone who's playing sports, I don't know, 20, 30 years old, how fast does he or she could go back to doing sports? How long does this recovery take?
Well, that's a great question too. I mean, the procedure itself is very quick. It's 30 minutes. And most patients are back to normal weight-bearing activity in about 6 weeks. Sport, we would say you would have to just be mindful of pain. You listen to your body. When you're ready to weight bear, you can start back with full activity. So, I mean, for example, we had a guy visit us. I mentioned this patient. He came to the office on Wednesday. He's had his Episealer in for 1 year, and he did a 10K race about 9 months in post-operatively. That was sort of his first big sporting event. No, 9 months post-op.
Geez, I may ask for that implant because I want to do a 10K. I never have done one. Okay, very good, Rosemary. I'd like to thank you for coming out, to spending the time and explaining what Episurf is. And thank you, Gene. Thank you, Francesca, for coming out. And I'll send you a copy of the video.
Super. So, and can I just say, if anybody wants more information, please go to our website, www.episurf.com. Give us a call. We take direct inquiries from patients, from surgeons, whatever you want to, whatever questions you have. We will, because we're a small company, we talk to everybody. We can get back to you personally.
Very good. We look forward to see how your company grows. So thanks everybody for coming.
Thank you. Okay, cheers.